Yeah. Good evening, all. We are from IIP. I, Dr. Kundan Chopra, welcome you all for this monthly online webinar on protocols in pediatric practice. This is one of the well appreciated and well sought program in MyIP platform. As you all know, in these protocols in pediatrics, we bring experts in the field of pediatrics to guide us. They compare various protocols and give us practical guidelines to all practicing pediatricians. And today's topic is autism spectrum disorders. I once again welcome all office bearers, EBs, and all pediatricians from MahaIP family for joining this webinar. I would like to welcome Dr. Samir Dalwai sir as a chairperson for today's webinar, Dr. Kashmiri Barbade as an expert for today's webinar, and Dr. Ramakant Patil sir as a senior pediatrician from Nashik as a MMC observer for today's program. We are meeting after a gap of 2 months. First, we skipped because of Mahapedicon preparation, and what a great conference it was. I would like to congratulate organizing chairperson Dr. Sanjay Pakmode sir, Dr. Kush Junjunwala, organizing secretary Dr. Sanjay Deshmukh sir, Dr. Pankaj Agrawal. And last month, we skipped because of CIP elections and code of conduct. I would like to congratulate all newly elected EBs from Maharashtra, Dr. Praveen Gokhale from MMR region, from Maharashtra, Dr. Amol Pawar. He has got highest vote second time in a row. Dr. Deepa Firke Madam, Dr. Sanjeev Doshi, Dr. Vinayak Patki, Dr. Nikhil Pathak, and Dr. Rajesh Kulkarni. And hard luck to my friends, Dr. Girish and Dr. Hemant sir. And also hard luck to Dr. Minaz and Dr. Ram sir. What I like about this is that immediately after election, second day, Dr. Ram sir posted one message in our protocol group. That message was, let us get back to work. And that should be the spirit. Elections will come and go, but IIP will remain, and its work should continue. So I request Dr. Ram sir for his opening remarks. Sir.
Thank you, Kundan. Good evening, friends. Now, as the December is approaching, this would be the last session of this particular headings, that is protocol in pediatrics. We will have few more sessions till 31st December. I welcome the new president, upcoming president, Dr. Sanjay Pakmode. Now he will have all the programs. Let us wait for his announcement. Now, as the title says, the protocol in pediatrics. So today we will learn the protocols in autism spectrum disorder. And I welcome Dr. Kashmiri Barbade as a speaker. But at the same time, you know, Dr. Samir Dalwai, he is the pioneer person in all these disorders and adolescent medicine. So I welcome Dr. Samir. At the same time, we know that he is a next candidate from our Maharashtra for the president of CIP. So even I would request everyone to get ready for the next year. And we have to see that he should become the CIP president from the Maharashtra. So yes. I welcome Samir Dalwai sir. Yeah. Over to you, Kundan.
Yeah. I now request ever energetic, ever smiling Secretary General Dr. Amol Pawar to say a few words.
No. First, Dr. Sanjay Pakmode sir, please.
Yeah.
Yes.
Sanjay Pakmode sir, good evening, sir.
I'd like evening.
To have
Am I audible?
Remarks, sir.
Yes.
President Ram sir, Secretary Amol, today's MMC observer, past President Dr. Ramakant Patil, and Chairperson Dr. Samir Dalwai sir, today's speaker Kashmiri Barbade madam, and today's moderator Kundan Chopra, and all the Matin Sheikh and all the people who have joined for today's this particular webinar. I welcome all of you. And as sir has said, this is going to be the last in his presidency or in his tenure. So we will like to continue all the projects which sir has conducted in his tenure and which were very useful for the people of Maharashtra IPNs. So we'll definitely continue all those particular projects which sir has did in his tenure. And we know as Samir Dalwai sir is doing a very excellent work in developmental pediatrics. And we all have heard him, rather in the whole year we have heard him so many times. Every time it is something which is new, he teaches us. And that is the really wonderful about his, he talks very well. And he knows the subject very well. About the but Kashmiri madam is also doing the good work. So would love to we'll listen from the madam today. The that is autism spectrum disorders, the different cases, and whatever the insights into that particular topic. So over to you.
Yes.
Kundan.
Thank you, sir. Thank you, sir. Now I'd like to ask Dr. Ramakant Patil, sir, today's MMC observer and past president Maha-IP. Sir, joined?
Yes.
Yes,
Yes,
sir.
yes.
Good, sir.
Thank you, Kundan. I wish all the best for this excellent program. I appreciate and present my thanks to Dr. President Ram Gopal, Secretary Dr. Amar, and his team. And we expect that similar academic feast is going to be there in next year under aegis of Dr. Sanjay Pakmode and Dr. Amul Pawar and the team, incoming team. And we know the Kashmiri is the new young white academician, and we all here to listen to her. I recognize the presence of my friend, philosopher and guide, Dr. Samir Dalwai, and is really a chocolate hero of CIAP. And we are again, it's not only the chocolate hero by his demeanor, presence of mind, the excellent academic depth which we have witnessed over last 20 years. And we really appreciate the way he presents it, and there is an out-of-box thinking and in between the line thinking, how to present and approach this behavioral disorder. We are really many times impressed and amazed how he presents and simplifies the thing. And he is going to supervise how the new dynamic young academician is present to us. Over to you, Kundan. Thank you for giving an opportunity to have a word with you.
Thank you, sir. Thank you. Now I'll ask Dr. Amul Pawar to say a few
Yes.
words.
Thank you. Thank you, Dr. Kundan. After hearing all three president, past president, and today's MMC observer, Dr. Ramakant Patil, sir, President, Dr. Ram Gopal Chezara, sir, President-elect, next year President, Dr. Sanjay Pakmode, sir. I welcome all of you, and again, I welcome past national president, past national treasurer and president to be Dr. Samir Dalwai, sir. Today's speaker, Dr. Kashmiri Badbade, madam, and Dr. Matin and Dr. Kundan, moderators of this protocol of in pediatric practice. And I welcome all the office bearers who have all joined from various parts of Maharashtra as well as India, delegates, then PG students. So as already Ram Gopal sir has told about this series of webinars, these protocols, these are very necessary for all the general pediatricians as well as all the intensivists to follow in their routine practice. So we have covered almost many of the protocols during this year, and again next year will be again full of academics under Dr. Sanjay Pakmode, sir. So without wasting time, I request Dr. Kundan Chopde to go ahead. Thank you. Thank you.
Thank you. Thank you. We are fortunate to have Dr. Samir Dalwai, sir, as chairperson for this session on autism spectrum disorder. It is very difficult to introduce somebody who is already well known. He is developmental and behavioral pediatrician who is dedicated his career to deliver innovative interventions to children with special needs and their families. He is recipient of Government of India's Rajiv Gandhi Manav Seva Award for services to children. He is founder, director, and consultant at New Horizon Child Development Center, Mumbai, and is development pediatrician, pediatric-led multidisciplinary team with 6 centers and now 1 center in Baroda also, and an online intervention program for children with special needs like autism, learning disorders, intellectual disability, ADHD, and adolescent cancer. His center provides individualized assessment and intervention to children with developmental and behavioral concern. He and his team have proposed the social interaction theory of autism as well as social behavioral communication sequence of development. His current work is around delivering online intervention program for children with special needs. He is also attached to Max Nanavati Hospital, Mumbai. As the national treasurer of IIP, he is able to resolve a tax demand and he hence saved IIP a sum of whopping 9 crore rupees. He is editor-in-chief of IIP Handbook of Developmental Behavioral Pediatrics. He is national coordinator of the IIP Fellowship of Developmental Behavioral Pediatrics. He heads the media committee of IIP के बाद community के साथ, and he is the national convener of IIP ICP certificate course on behavioral disorders and autism. He is the past chairperson of the IIP chapter of neurodevelopmental pediatrics and also past president of IIP Mumbai. He is the founder member of Young Indian Parliamentary Citizen Alliance Against Malnutrition, a member of expert panel of Maharashtra, State Commission for Protection of Child Labor, and he served as a member of Maharashtra Pediatric COVID Task Force. And he has numerous publications to his credit and delivered oration lectures and guest lectures across India. Sir, please enlighten us. Yes, sir.
Thank you. Namaskar, Pranam Sarvana. I am very happy to be here and I am grateful to our dear President, sir, Dr. Ram Gopal Chezara ji, President-elect, sir, Dr. Sanjay Bhai, who organized such a wonderful conference recently at Nagpur, our dynamic, ever smiling Secretary, Dr. Amol Pawar, sir, both the coordinators today, Dr. Kundan, Dr. Matin Bhai, as well as my dear friend, elder brother, past president, Dr. Ramakant Patil Sahib, and our young dynamic, the person, see, it's very easy to sit in a metropolis. The luck that I have had to be in a city like Mumbai and do something in development pediatrics. But to take this specialty to the other parts of Maharashtra and to establish it there like Dr. Kashmiri Badbade has done is really, really amazing and remarkable. And I congratulate you, Dr. Kashmiri. Karan, for this subject, there is nobody to guide you or look after. You have to establish your own way. And you are doing that. And I really congratulate you for putting up a team there. And also, I'd like to welcome and say hello to all my other friends from Maharashtra IIP as well as the rest of India. I see Dr. Anna Sahib here, many people, the executive board members from Central IIP as well as from Maharashtra IIP. And thank you so much for this wonderful opportunity. Having said that, development pediatrics आणि protocols काय संबंध आहे? प्रोटोकॉलचा जो तुम्ही टॉपिक घेतलाय मला खूप त्याचा आनंद वाटला कारण काय असतं बऱ्याच वेळा आपण MBBS MD पर्यंत चांगला अभ्यास करत असतो जे अभ्यास परीक्षेला जायचं असतं आपण लेटेस्ट अपडेटेड असतो एक्झामिनरला परीक्षेला येताना भीती वाटत असते आणि त्याला वाचून यायचं असतं पण एकदा आपण पास झाल्यानंतर रोजची जी आपली जी जीवन गाथा असते त्याच्यात प्रॅक्टिस एस्टॅब्लिश करणं आपले पाय जमवणं आणि घर चालवणं ह्या गोष्टी जास्त प्राथमिक वाटतात आणि हळूहळू आपलं जे एक अकॅडमिक बेंट असतो तो पाठी राहू लागतो आणि स्पेशली इन अ स्पेशालिटी विदिन 1 or 2 or 3 years things have moved ahead. This problem, and I am going to say it, Muddamon, pardon me, President sir, President-elect sir, Amol sir, this problem is faced more by the ladies of our profession than the gents. मला कुणाच्या बद्दल मी पुरुषांच्या विरोधात आहे असं नाही पण very often till college the girls are the ones who get the gold medals. पण नंतर वेगवेगळ्या आपल्या ज्या फॅमिली सोसायटीचे एक प्रथा आहे इट्स नॉट गुड पण त्याच्यामुळे गर्ल हॅज टू ऑलवेज सॅक्रिफाईस आफ्टर सेट्स अप प्रॅक्टिस देन शिफ्ट समवेअर एल्स आफ्टर मॅरेज सेट अप प्रॅक्टिस अगेन देन फॉर द चाइल्ड शी हॅज टू सॅक्रिफाईस अँड विदिन 2-3 years द स्पेशालिटी हॅज मूड आणि यू लूज दॅट कॉन्फिडन्स आणि तुम्ही विचार करा सर्वांनी याच्यावर मग खूप गंभीर इश्यू आहे आपण फक्त बेसिकली दॅट पर्सन फील्स कम्प्लिटली आउट ऑफ टच and people who may not have been as good or as sincere, she finds that they have gone ahead and it hurts and then she has to do some secondary kind of a role. I am very happy today Kashmiri has been a champion for such things, that she has herself taken a specialty and not allowed any of the routine things that actually are a lot against, allowing a level playing field, and you have established that. I am also very happy that in my own team at New Horizons, we have 3 or 4 people who are doing private practice as an assistant somewhere else, and we have coached them to be development pediatricians. So, Dr. Kashmiri, what you are doing is extremely important. Why protocols? Because people who may miss out with that academics, how do they catch up with the academics? Should they go back to college? Should they do a fellowship? It's not possible. आपल्याला घर चालवायचं असतं, मुलं आहेत, घरी आई बाबा have retired. प्रोटोकॉल जे डॉक्टर रामगोपाल मी त्यांना मित्र म्हणून रामगोपाल म्हणतोय पण प्रेसिडेंट सर आहेत अमोल सर आहेत त्याने जो हा टॉपिक घेतलाय प्रोटोकॉलचा इट इज व्हेरी इम्पॉर्टंट फॉर ऑल ऑफ अस इन प्रायव्हेट प्रॅक्टिस कारण that is a quick catch up in 1 hour of the latest things that's happening in the field. आणि एकदा एक्सपर्टने जसं आज काश्मीरी सांगणार आहे आपल्याला, आपण ऐकलं आपण की आपल्याला परफेक्ट कॉन्फिडन्स येतो की आता काय केलं पाहिजे. अँड देन आपण पाठीपाठी राहत नाही, वी कॅन डू द बेस्ट. अँड हेन्स टुडे इन ऑटिझम स्पेशली इज अ फील्ड वेअर प्रोटोकॉल्स आर व्हेरी इम्पॉर्टंट, बिकॉज नॉर्मलच ऑटिझम कसं ओळखायचं, कसं सस्पेक्ट करायचं, इन दॅट इट सेल्फ वी हॅव अ प्रॉब्लेम. So the protocols in autism, I'm sure Kashmiri will do justice to it, is not just for management, also how to recognize and what is the right way to go ahead and to deal with this. And the role of the pediatrician is most important. आणि हे मला आवर्जून सांगायचं आहे. Please don't think developmental pediatrics is a subject of the developmental pediatrician or the therapist or the neurologist. Because the percentage of children who have developmental disorders or problems is up to 30%, if not more. 30% 30% पेशंट्स ना बघायला आपण कुठून डेव्हलपमेंट पिडियाट्रिशियन आणणार आहोत, कुठून थेरपिस्ट आणणार आहोत. आणि मग आपण म्हणतो ना आमच्याकडे थेरपिस्टच नाही, आमच्याकडे डेव्हलपमेंट पिडियाट्रिशियनच नाही. असं नको व्हायला. पिडियाट्रिक्सचाच भाग आहे डेव्हलपमेंटल पिडियाट्रिक्स. आणि इतर पिडियाट्रिक्सचं तुम्हाला काही नाही आलं तरी चालेल, पण डेव्हलपमेंटल पिडियाट्रिक्स शिवाय आपण पिडियाट्रिशियन होऊ शकत नाही. आणि हा भाग कॉलेजमध्ये कुठेतरी पाठी राहिलेला असतो. आणि अशा IAP महा-IAPच्या कार्यक्रमाद्वारे तर पुढे आपल्याकडे प्रोटोकॉलच्या द्वारे पुन्हा आपल्या समोर सर्व हा इश्यू आणला. ह्याच्याबद्दल मी विशेषतः डॉक्टर रामगोपाल, डॉक्टर अमोल, डॉक्टर संजय, डॉक्टर मतीन आणि डॉक्टर कुंदनचे खूप खूप आभार आणि कॉंग्रॅच्युलेट करतो त्यांना. आणि डॉक्टर काश्मीरी सारख्या ग्राउंड लेवलला काम करणाऱ्या व्यक्तीला तुम्ही वक्ता म्हणून आणलाय, म्हणून तुमचं विशेष अभिनंदन. So the whole point is keep your eyes and ears open, not only for the next 1 hour, but every time in your OPD you see a child, whatever you observe from the child, whatever history you take from the parents, and then whatever you are telling the parents, then you may refer, keep the track of the child, keep monitoring the child. मला आज एक खरी गोष्ट तुम्हाला सर्वांना सांगायचं आहे. मी कुठलाच मोठा कोर्स केला नाही, कारण 1997 मध्ये मी पास झाल्यानंतर डेव्हलपमेंट पिडियाट्रिक्सचा काही टॉपिकच नव्हता. पण सुरुवात 2003 पासून केली. पेशंट बघायचे. सुरुवातीला फक्त थेरपिस्ट काय बोलतायत इंग्रजीत ते मराठीत हिंदीत पेशंटला सांगायचं, हे मी काम केलेलं आहे. तुम्हाला कदाचित शॉक वाटेल, तुम्हाला आवडणार सुद्धा नाही, पण मी असं सुरुवात केलेली आहे. कोणी मला शिकवलेलं नाही, कुठलाही कोर्स मी तेव्हा केलेला नाही. आता आम्ही फेलोशिप चालवतो चॅप्टरमध्ये IAP मध्ये, पण तुम्ही सुद्धा हे करू शकता. असं काहीच त्याच्यात नाविन्य किंवा वेगळेपणा नाही. Start seeing patients, start telling them what to do, but follow up. You learn from follow up. Once you see how your advice has worked, you will learn. And of course, ह्याच्यात definitely will be a striking illumination by hearing our speaker today. At least start with what she has said. It is not the end. This may not be the protocol next year, but this is for you to practice for 1 year. Try what is happening. See how the patient responds. Keep monitoring even if you refer somewhere. See whether the patient getting better or no and discuss with each other. एवढंच म्हणून मी I'll thank once again MyIAP platform, this entire program of protocols, and all my dear friends and brothers who are here to do this program again. And thanks to all of you for attending this. इतर प्रोग्राम अटेंड केलेत की नाही, पण प्रोटोकॉलचा प्रोग्राम मिस करू नका. धन्यवाद. नमस्कार.
थँक्यू सर.
Thank you, sir. Kundan, 1 second.
Yes, sir.
Already we are having more than 200 delegates, so that shows the success of the program. And special thanks to Dr. Sanjay Pakmode sir, because he has decided to continue all the series which was started. So thanks to sir. I think probably people are also adjusted with all these sessions having different topics under different categories. So once again, welcome all, and over to Kundan.
Thank you, sir. Thank you, Samir, sir. The 3 things distinguish pediatrician from physician, that is development, nutrition, and anthropometry. Development is most important thing in the history we have to take. And today we have selected topic autism spectrum disorder because now the awareness of parents is increasing about autism. In our busy OPD, the parents do ask the question, doctor, is my child is having some features of autism? They have read somewhere articles and they do ask this question. So we have taken this topic and we have eminent pediatrician, developmental pediatrician, Dr. Kashmiri Badbade to guide us. Madam, can you put the CV? Madam.
Hello, ma'am.
If you have any questions, feel free to post in the chat box. So at the end of session, we will make sure that we'll address all your queries. So please post your questions in the question box. Dr. Kashmiri Bedbade is a developmental pediatrician at Ichalkaranji and Kolhapur. She is the director of Tender Steps Child Development Center, Ichalkaranji. She is consulting developmental pediatrician at Kolhapur, Sangli, Nipani, Pandharpur, and secretary at Sarmati Intellectual Disability Schools, Ichalkaranji, and co-director at Disha Learning Disability School, Ichalkaranji. Her achievements are: she is Maha-IP Women's Committee EB in 2024. She was secretary Kolhapur Academy of Pediatrics in 2023. And EB of Kolhapur Academy of Pediatrics in 2021, 22, and 24. She has contributed for module HINA and high-risk newborn assessment, and also for tiny to tall OP SIS CIP 2024. And her areas of interest are early intervention, autism, ADHD, and intellectual disability. Without wasting much time, I will hand over mic to Kashmiri. Welcome, Kashmiri.
Thank you. First of all, I take this opportunity to thank Maha-IP. Firstly, the President, Sir, Dr. Ramgopal Chezara, Sir, and President-elect, Dr. Sanjay, Sir. Also, I would like to thank Secretary, Dr. Amol Pawar, Sir, and obviously my guide and one of my inspiration, Dr. Samir Dalwai, Sir. And also wants to thank for this because he has shared the articles with me and that I'm going to present and I'm going to talk on. So thank you everyone. Thanks to the coordinators, Dr. Kundan and Dr. Mateen. So without wasting much of a time, I'll start with my topic. I hope I will do the justice. Sir is there to guide.
Yes.
So visible?
Yeah, visible and audible.
Yeah. Today's topic, protocol in practical pediatrics, autism spectrum disorder. So as we have seen, now we are hearing about the autism and everyone is aware about the autism. But the first first article was published in 1943, which was by the Leo Canners, and then which was studied on 11 children only. And then Hans Asperger has come up with the paper Autistic Psychopathy in 1944. Then there are many papers published after that in American Academy of Pediatrics, NICE, IAP, consensus statements, also the consensus statement of IAP in 2024 on the habilitation of children with autism spectrum disorders. And also there is a autism assessment pathways has been published. So I tried to put together the important protocols. So before going to the protocols, like what is autism? So we all know that autism spectrum disorder is a common neurodevelopmental disorder with the core deficit are identified in two domains, like social communication and interaction and restrictive repetitive patterns of behavior. So as we all know, the umbrella now, the autism spectrum disorder is the umbrella of pervasive disorders, then autism disorders and Asperger's. Now we don't put the Rett's into this umbrella, Rett's disorder. So the prevalence of autism spectrum disorder worldwide now, it is 1 in 36 in United States and 1% in the world population. India, the limited studies are there and only 4 studies in India till date. And each studies, they have used a different assessment tool. So suddenly there is an increase in the prevalence, what we all say. So the attribute was now to put criteria and to diagnose the child, Dr. Kundan said, and the screening, and then availability, early intervention and based services, diagnostic substitutional from the intellectual disabilities. Also, the globally, the similar in the United States and industrialized countries and lower in the resource limited countries. The surveillance, as we have from 2014 to 2020, it is 1 in 36. So socioeconomic status, higher socioeconomic status linked to the earlier diagnosis, and the lower socioeconomic status has later diagnosis and limited access to resource services. As just Samir sir said that limited resources, very where I'm working, actually nothing was there when I entered in this city. So it was completely gray, and nobody was knowing what development is. So starting from a scratch was very difficult, catching the patient, getting them for the follow-up. And the worst part was in the periphery, far the transport systems are not good, they are economically not well, they are not aware also, and they are not aware about the condition, and they are not aware about, they don't have the seriousness about the child development, what will be the later prognosis of spectrum disorder. So all these were the barriers when I started with my practice. So etiology, there are genetic variation that causes the neural disconnectivity and that affecting the early brain development and may lead to the abnormalities in process information, like the basic skills. Like if somebody comes to you, if you see someone smile, so this smiling has to be there, the social skill has to be there. That the genetic predisposition could be a genetic deletion, duplication, or sequencing changes. There is a high level of consanguinity. Some studies showed maternal and paternal age, also the obesity, perinatal factors, epigenetic modification. So epigenetic also plays the major role. So concerns that the vaccine or preservatives in the vaccine can lead to the ASD. There is no evidence to support this claim. Also, there is a screen time, which they say that the screen causes the autism. As always, Samir sir said it is a genes which are there in the baby, and if that baby is watching a television for a long time or duration is more than, then that they likely show the symptoms, signs and symptoms of autism. Otherwise, the other kids, they usually don't show any signs and symptoms. So as I said, the perinatal factor like maternal infection, maternal drug exposures, environmental exposures to the heavy metals and phosphorus poisonings, and genetic factors as we have discussed, and unknown etiology. So global assessment standards. So what are they? The persistent deficits in initiating and sustaining the social communication, reciprocal social interaction that are outside the expected range of the typical functioning. Also, there is a persistent, restricted, repetitive, and inflexible pattern of behavior. I'm coming to you, on all this topic one by one. And interest or activities that are clearly atypical. Onset of ASD during the developmental period. So early developmental period, typically, but symptoms may not fully manifest until the social demand exceed. When the child starts going in the nursery or the preschool era, so then they feel that child is not sitting in the class, child is not mixing with the peer group, child is not maintaining the eye contact with the class teacher, and then they notice that their children is having some issues. The symptoms result in significant impairment in the personal, family, social, educational, and occupational or other important areas of the functioning. Screening. Why screening is so important and when to screen? So routine developmental surveillance in all the children by 9 months, 18 months, 24 months, and 30 months. So by 9 months, like if you meet a 8 to 9 month old child, so when you look at the child, he will look at you. He will maintain an eye contact. He will smile. When you smile, he will smile. He'll try to imitate you. Some of the facial experiences, expressions he will imitate. 18 months, he will. So screening at 18 months and 24 months with the MCHAT is important. And if the result is positive, then diagnostic evaluation by the developmental specialist, and negative, then the continue the developmental surveillance. What happens is many a times these mothers, they are, as said, the Google mothers, they come, they will ask, okay, my child is, I'm seeing this, and then when you perform the MCHAT, the score is low, the negative score screening is negative, and then they become relaxed. So there was some alarming signs. So you should keep a watch and you should keep a follow-up on that child. Then the DSM-5 diagnostic criteria for the autism spectrum disorder. So there is also a autism assessment pathway. So they have said that every child, identify every child and arrange for the referral. Then screen the child. After screening, pre-assessment support should be given to the child and the family. Also the autism assessment. Once the child is assessed, provide them the intervention protocol, provide the support and the post-assessment support. So all these parameters are very important, because it is very easy to tell us that your child is having autism, but again, what to do and guide them properly is very important. Supporting them is very important, because here in our scenario is like the mother is responsible for everything. Not a single family member will come and turn with her, and she is the only caretaker and she has to do everything. And after some time she gets frustrated, or and also she doesn't know what to do. So guidance is very important. Clinical symptoms, as we all know, by 9 months, poor eye-to-eye contact, 12 months does not respond to name, 14 months does not point to the object to show interest, and does not pretend play. So if we can remember, when we were kids, like we used to be roam around with our cousins, we used to play with the mother, we used to play with the household stuff, and that we used to learn a lot of things, everything. So mother is arranging the utensils, mother is doing something with the veggies, we used to hold it. So all the touch of the veggies, all the touch of the utensils, different clothes mother used to fold and everything. So all they used to give us the inputs, and this is how we learned. And then we used to roam around in the house freely. So these are the very important thing in the development, because see, when mother calls, you are with the mother, and mother doing something. If she is taking a bowl and she's making something, so even the child will pretend, he'll take a bowl, he'll take a spoon, he'll pretend that he's preparing something like a mother, or he'll try to prepare a chapatis, or he'll try to help in the household work. So these are all, and this is how we used to develop. So these are the normal development. So in any children, forget that whether you can diagnose autism or not diagnose autism, but at least diagnose this much, that the behavior of the child is deviating from the normal trajectory. That is what the message I want to give you today. So avoid in general signs and symptoms, avoid the eye-to-eye contact, trouble in understanding the people's feelings about, and also about their own feelings, has delayed speech and language skill. So what happens in the autism, when they come to us, they come with the only one symptom, that he is not speaking, and immediately the child will go to the speech therapist, and they don't know. And after 2, 3 years, 4 years, they will turn to us. Okay, now by 4 years or by 5 years. So initially I have diagnosed the autism at 10 years, 12 years. Now at least it is coming to the 5 years. Gives unrelated answers to the question, gets upset by the minor changes. They cannot accept the minor changes. Even the child, when they come to our therapy center, and if the therapist, today there's some different therapist is there, they are not ready to adjust with that. So it is very difficult for them to change with the minor cope up with the minor changes. Has obsessive interest. Obsessive interest means, you must have seen the many babies, either they will play with the car, or they will play with the ball, or there is some object. So when I'm taking a history, I take the history that is there any to die for objects with in the house. So to die for is, he has set the pattern and he'll be into it, and he'll keep on playing with that. And initially when he's playing with that, the parents and the relatives thinks that, okay, my child is very calm, quiet, nice child, he's playing alone. As soon as he start going into the school or the nursery, they'll recognize, no, it is something different. So if any to die for conditions, to die for objects are there, just try to remove it and keep the neutral things or like things in front of him. Then they make a repetitive movements like hand flapping, rocking, spinning in circle. Also there is a unusual reactions to the senses like sound, smell, taste, look, and feel. So as I said, you should know the normal trajectory. So social interaction, whether in normal they enjoy the play dates, avoid the social situation in abnormal behaviors. Emotional responses like display the varied emotions. They will laugh, they will make faces, they will cry, they'll do a lot of emotional responses, like they will be very nostalgic to you. Then there is like extreme reaction and disproportionate to the situations in abnormal behavior. Then the learns from the mistake. For example, there is one block or one chair in the middle of the hall, and if they are passing, and 2-3 times the child may get hurt with that chair, but third time the normal children will learn and he will turn aside and he will walk off. But these children, they are persistently doing the same mistakes again and again. They don't like register, okay, this I'm not supposed to do. Then developmental process meets the milestone on the schedule or little plus minus, but significant delay in the skills. Some or other skill will be significantly delayed. So I have just put this video. I just wanted.
देवांश, तुला काय हवंय? काय पाहिजे तुला? फुल पाहिजे. बरं, देऊया आपण फुल.
So have you seen this child? I was communicating with the child. He has come to the OPD. He was just a normal child. He walked off like that only. He was a relative of one patient and he entered in my OPD. And when I was communicating with him, see, when I said Devansh, he responded to name. He has given good eye-to-eye contact. He listened first. He has to listen. So the listening is good. Then he was doing an appropriate talk. When I asked what you want, he said, I want a flower. And then when I said, can I give you a toys? Then he was very excited. I could not put the whole video, but then he was very excited. He was searching for the toys, where it is, and explore the things. So this is a normal behavior of the child. So here with the 3 questions, we can assess that, okay, what is your name or what you want. So like the hearing is there, he's responding, receptive speech, with the understand, he understood my question, he processed it well, vocalization is there, articulation, whether the speech is clear, fluency is clear, or there is any other issues, rhythm is clear. So all these things we can assess just by asking few questions to your child. So look at this. So some behaviors parents struggle with, like the child may crying, tantrums, flopping to the floor, not listening, not studying, or not taking interest in the older ages, aggressive behavior, arguing, fighting. So look at this girl. This girl is a 16-month-old girl, and again they read something on the net and they came to me just for a consultation. See how she's throwing the tantrum. She wanted some mothers first, and she said, I'm not going to give. So for that, she's just simply throwing the tantrums. So what should be done then? So I observed this child, took her into the playroom, and I just observed that she was doing everything normally, good eye contact, responding, everything she was doing. Only the point of desire, like if I want this, I want this. This is the tantrum she has started showing. Now this. Is audible? His name is Kedar. He is 2.5-year-old child. He's 2.5-year-old child. I'm calling her 4-5 times. I'm just calling her entire video like Kedar, Kedar, Kedar. He's not responding. He's just moving. He's showing some toe walking because this floor is new to him. So he's showing some sensory signs. Now look at this. Look at how he is walking. He's doing tap, 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 tap.
Rishikesh.
Is not responding to name. Poor eye-to-eye contact.
Rishikesh.
So
Rishikesh.
Before going further, just we should look for the functional causes of the behavior. Why child is showing the behavior? The autism is there. Okay, we diagnose the autism. Now, what are the functions of the behavior? So, like functional behaviors. So there are the attention-seeking behavior, where the child he wants to seek your attention, and for that he will throw a behavior. Then the tangible behavior, basically for the preferable object. What we say is the hetu puraskar. So he wants this, means he will throw a tantrums, and he will throw a behavior, and he'll throw till that time till he gets back that stuff or that object or point of desire. Then the escape behavior. So many times they just want to avoid or get away from that task or get away from that situation, and for that behavior. And the sensory behavior, it is because of the sensory, they feel good or they may not feel good to the situation. It could be a visual, it could be a hearing, touch, or a smell, or a taste. For anything, they may throw a behavior. So that is a sensory behavior. So just before going, let's learn the ABC of the behavior. So what is the ABC? Everyone, what is the ABC? Like antecedent, behavior, and the sequence. So antecedent, why child is doing this, what kind of behavior he's doing, and what he's getting after that, the consequences. So just an example, Radha wanted ice cream at the lunchtime. Mother says no. She started throwing himself on the floor. So she showed a behavior, and then mother gave the ice cream. So she got the desired stuff. So this is a tangible behavior. So हेतु पुरस्कार, तिला जे पाहिजे होतं ते तिला मिळालं. Then second is the father asked Rahul to go for a bath. He's like, I don't want to go for a bath. And then he started throwing the tantrums. And then father said, okay, don't take a bath today. So this is like he wanted to escape, and he could escape because he got the desired things. Like, okay, I could escape from this, and मला नाही करायची अंघोळ, मी नाही केली. Then the one more, that mother is talking on a phone. This is a very common scenario in all the families. Mother is talking on the phone, and then the baby will start shouting, screaming, or just behave something differently, and then mother will cut the call and scold Rahul. So this is a attention seeking, because he wants the attention of the parents or mother or caregiver. So this is again steaming. We talk a lot about steaming. So it is a repetitive body movements that is self-stimulatory, either a sideways gaze, running in a circle, or jumping and clapping, chewing, rocking back and forth. So the repetition of the word, we call it as echolalia, repeated throat cleaning, or humming, or hand flapping. So she's the girl. So why they are doing that? Because there is when they're doing these activities, there is a release of the beta endorphin, that is a dopaminergic pathways get activated, and they get a pleasure out of it. So in this condition, we need to just take away from that merry-go-round or whatever they are doing. Just not saying that oh, don't do that. Never say that. Just take her and just show her something else, or divert her from that point. So other than that, we can see the angers, dealing with the changes, difficulties, they get distressed easily. Eating issues are more common with this children's meltdowns, then sleeping disturbances, organizing and prioritizing, and self-injurious behavior we can see. So why all these things are happening? What happens is, like, they misread the social situation, or there is a lack of sense, or the following the sequence. So after this has to do, after this has to do. Easily distracted by the strong interest, dislike getting the messy, anxious or annoyed of change in the routine, or sensory inputs, or haircut, loud noises, light, touch. So all these things, these are the risk factors. With that, they may show they may get a sensory overload and can lead to the meltdown. So what is a meltdown is like all the sensory inputs, as I have said just now, that the sound, smell, light, taste, touch, visual stimulation. So many a times, these are the kids, they may behave very hyper or hypo. Many kids, they behave hyper. And in that, they get misdiagnosed, and they misdiagnosed with the ADHD. Many a times it is labeled that child is having the ADHD, and the poor child is getting treated for the ADHD for a long duration. And then later, when he enters into the school or in the primary section, then we diagnose, no, it is not ADHD, it is a behavior of the autism, and child is having the autism. Screening is very important. DSM-5, we all know the social, we look into the social communication, repetitive behaviors, early onset symptoms, impairment, and exclusion, whether it is an intellectual disability or global developmental delay is there. In New Nelson, they have come up with this new things like the typical language development and abilities. So less than 6 years, they have a delay in the comprehension, and more than 6 years, they have the difficulties like pragmatics, semantics, and morphology, this kind of difficulties. And the very important is the motor abnormality. So these children, even up to the 2 years when we diagnose, they may show a hypotonia. Some of the children, they shows the hypotonia, motor delay, and deficit in the coordination, movements, and then the preparation and planning, so gait, balance. So all these things that they may show motor abnormality. Diagnostic tool. So early and accurate diagnosis is crucial for the effective intervention. So remember, everyone should go through like MCHAT. Everyone should do that. Even you can train one of your staff, nursing staff in the hospital, and she can do the MCHAT for you if you train properly. Then the ADOS, CARS, simple test, which I don't have all this fancy test. I do MCHAT, INCLIN, and ESA. That is what available in my setup. So I do that. Diagnostic evaluation. Along with this, we have to do the physical examination, look for the dysmorphic features, muscle tone and reflexes. Then the head circumference. Also look for the tuberous sclerosis. Diagnostic testing, like if required, you can consult. And CMA, Fragile X, hearing and visual evaluation is very important. And lead test if the child is having a pica, eating disorders. So additional target testing like genetic, as we all know, we have to go through karyotyping. And if these children are more shows the comorbid conditions like the epilepsies, so EEG is important, MRI as and when needed, metabolic workup, and if required, whole exome or genome sequencing. So barriers to identify the risk for ASD. First, if the symptoms are mild or child is showing the average intelligence, so it is like very difficult for us to diagnose, and the diagnosis may get delayed. And once the child enters in the formal education, then only we will diagnose that. So gender, the girls sometimes it masks the situation. So, and they remains underdiagnosed. So I was having a girl, she was intellectually, I mean, the way she was talking and the way she used to understand. So when at the age of 3, she was talking 5 languages. She used to, because the screen time was too much, she was talking Hindi, Marathi, English, Russian, and Korean. So when I used to sit with her, okay, this is square. So she used to say it in a different language. Then I used to ask, which language? Then she said, no, it is a Korean or it is a Russian. So that is how she used to tell me. She used to appropriately answer me. So knowing that it is a autism, and then later the parents got diagnosed because she was talking, she was moving, she was doing all the things. So parents got confused. No, it is not autism. It is just she is a hyperactive. Then existing conditions like ADHD can delay the ASD diagnosis up to 3 years, as I just said. Then the surveillance and the diagnosis as the barrier. So screening and referral due to the unmet health needs. So as where I'm working, it is very difficult to pull the patients and tell them to screen yourself and do it in one setting only. Once they come, I have to do everything and tell them, okay, no, this is this. So this is very difficult in the peripheral scenario. So socioeconomic status and cultural barriers, race, ethnicity, socioeconomic status do not affect the screening accuracy, but the language and low literacy, because they don't understand the question what you want to ask. And the cultural differences, trust issues, and may limit the symptoms reporting, because these children are moving. These children are physically, almost 80% children are physically normal. So they feel that nothing has happened, only he's not speaking, or only he's not looking, or only he's little hyperactive. So it'll resolve. So there are a lot of myths in the society. Also, the need for improved screening tool, because it is in the English. So other languages also we need to develop. And just now I said the comorbid conditions in ASD. So intellectual disability is also one of that. So when I have just given the example of the girl who was talking 5 languages, I'm following her since last 6 years. Now she is in the 2nd standard, and then we started seeing the difficulty in learning. Then when I assessed on the learning, then we came to know she is having the learning issues also. So that every child who looks like he is talking and doing well is not intellectually disabled, or he's not learning disabled. It is not like that. So 2 things are different. Seizure disorders, ADHD, anxiety disorders, sleep disorders, behavioral abnormalities, eating and feeding disorders, and cerebral visual impairment. Differential diagnosis, we should know the differential diagnosis, whether it is, see, every symptoms, autism mimicking symptoms is not autism. It could be something different also. The social communication disorder, language disorder, intellectual disorder or global developmental disorder, hearing impairment. Here we diagnose the hearing impairment at around profound hearing loss by 4 years, 3 years, and feel very, very bad. We are losing we lost such a crucial period of early childhood development. Then the ADHD, social anxiety and other anxiety disorders, reactive attachment disorders, obsessive compulsive disorders, and of course the genetic syndromes. So the prognosis and developmental trajectory in ASD, so more than 80% of the children diagnosed before the age of 3 retains their diagnosis. And mild symptoms in the children under the 3, especially with the average or above average cognitive abilities, can be harder to recognize. As I said, that it's 80%, they feel that nothing has happened. They are not ready to accept. They will retain the diagnosis. And developmental changes, improvement in the communication and social effective symptoms during the early childhood, if we'll start the therapies early, changes in the repetitive behavior due to the maturation and also the interventions, and language impairment correlates with the greater social difficulties. Intellectual disability complicates the social development. If the intellectual disability is associated with the autism, then the social development is likely to be complicated. Then the prognosis, again, long-term outcomes. So approximately 9% may not meet the ASD criteria by the young adulthood. So they shift from the diagnosis of the ASD. Only thing is that we need to keep a developmental surveillance of the child, because see, every age the problems are different. In the preschool area, the problems are different. In the schooling, they need to sit they need to understand what the teachers are saying, they need to get along with the friends. And the later age, in the pubertal age, they need to deal with the puberty, they need to deal with the changes, and also there is a transition from the adolescence to the adulthood. So all these things, we need to keep monitoring, and we need to counsel the parents, and there has to be a one-to-one conversation with the parents and with the child once the child grows up. Then predictor of outcome, improvement in the verbal IQ predicts the better outcome. Executive functioning difficulty shows the low adaptive outcome regardless of the IQ. Then the childhood IQ and language ability predicts the adult outcome. And quality of life in high functioning adults linked more to the family's community support than the ASD symptoms. So what should be the goals of intervention? There are a lot of interventions available in the market, like this we have to do, that we have to do, but somewhere it has to be like goal setting, like minimize the core symptom if child is having the social communication, interaction, then repetitive behavior, then maximize the functional independence and adaptive skills of the child, and to prevent and reduce the problem behavior, as we have seen the behaviors, as we have seen the how child should be functioning well. Then the characteristic of the effective interventions are individuals, developmentally appropriate and intensive, also based on the structured and scientific evidence, and regularly evaluated, adjusted based on the performance data. So the evaluation of the child, whatever you're doing, just evaluate the child. Not if it is not possible for you to evaluate every month, at least every 3 months you should evaluate. Then the effective interventions are like assessment goal, which just we have seen. Then the instruction methods, like address the core symptoms and provide the child and therapy ratio low enough to address the child individualized goal, and ensure that the multiple providers make the works collaboratively, because many a times there are 3-4 therapists who are working together. Sometimes we need to give the OT also, sometimes we need to give the applied behavioral analysis, sometimes we have to give the speech therapy, they may require the physiotherapy also. So all this should be all in loop, and it's not like I'm doing speech therapy is good, physiotherapy is good, or OT is good. No, it's a combination. We require all. So the communication between all the groups has to be there. Environment, provide a structured learning environment that helps the child anticipate the transition between the activities, including a predictable routine and visual activity schedule. So basically what MKC Nair sir used to say, that the patient will be with you for half an hour, maximum 1 hour. But 23 hours, the patient is with the families. So it is very important that the environment in the family has to be like learnable environment, and your parent should be well educated with the knowledge, with the disease, what it is and how. I am not saying that you make the parents a therapist. No, the routine has to be like adjusted in such a way that every learning opportunity he should get in the home environment. Organize the workplace to minimize the distractions and limit the access to the things that may distract a child easily. Also, the behavioral management is very important. Progress, the systematically measured and document the individual child progress and family support. So involve and educate the families so that they can use the behavioral strategies at home, not the therapies, but the strategies they can use. And the transition plan from school to adolescence, like now child is at home, then preschool, schools, and then the high school, and from home to the community living, that we have to plan. So again, I'll take the 1 minute over here. So any child coming to you, basically when I've started working, I've started working on these Fs. Like I used to see the functioning of the child, how the child is performing the activities, how the child is interacting, how to participating with the friends and other peer groups. Also the fitness, is there any fitness? Because many a times we see that all the kids are sitting in front of the screen and they are spending most of the time, even the normal or autistic, they are spending most of the time in front of the screen and become a potato couch babies. So fitness is very important. Then the fun part, whatever you're doing at home or in therapy center, are they enjoying that? If they are not enjoying, just manual therapy is not going to work. So child should enjoy. So for that, child should get connect with you first. Then the environmental factor, that is a family. So family plays a major role. And ask your family, what are the future prediction? What is your goal? What you want for your child in next 5 years, next 10 years, and set a goal accordingly. So if family sees the future of the child, they will work accordingly. And one more F I add is the finances. So finances are very important. They are if the finances is the problem, then it is really difficult for that family to manage all these things. So thank you.
Yeah. Thank you, Dr. Kashmiri Badbade, madam. I want to add one more word. You have fantastic presentation. I think you have covered this topic, vast topic of autism spectrum disorder very well in given stipulated time and covered most of the details. I will ask Dr. Samir Dalwai, sir, chairperson, to comment on this. Samir, sir, or meanwhile we can take the questions.
Sir is mute. Sir, you are mute.
Samir sir, unmute yourself.
Pallu ma'am, kindly unmute Samir Dalwai sir. And
Samir sir, unmute yourself.
wait, sir. Now Samir sir, please do.
Yeah, sorry. So I think it was the host which has disabled this thing. No, I think it's a fantastic, excellent presentation. Dr. Kashmiri, you have covered each and every aspect right from the earliest history of when Kanner wrote the first paper of autism to what is happening now. I think absolutely fantastic. All topics well covered. But if there are any questions, then I think it will be nice to hear the questions from the audience. What do you all think?
Sir, can you elaborate more on question from my side to you also?
Yes, go ahead.
Can you elaborate more on Ati Vastu Magnata and Kami Manusha Magnata and SRK sign? It's typical for you, signature.
This is basically something that I and my team have worked on and realized while working with autism in the last 22 years. And it is a little different from what the Western world or the Western literature talks about. What we have realized is that issues or how we recognize autism or what the parents tell us is that the child has poor eye contact, child does not respond to name call, child is hyperactive, child does not speak, does not understand speech, but keeps doing repetitive activities. We must understand that these are symptoms. पालक जे आपल्याला सांगतात, रुग्ण जो डॉक्टरला सांगतो त्याला आपण लक्षणं म्हणतो, सिम्पटम्स म्हणतो. सो दीज आर सिम्पटम्स. Unfortunately, the Western world has focused more on treating the symptoms, give speech therapy for speech, give behavior therapy for behavior, give medications for aggression. But the whole point is, what is the cause of these symptoms? Now, the cause obviously is genetic, पण एक्झॅक्ट जीन आपल्याला माहित नाही. पण आमच्या प्रोग्राम मध्ये गेले 22 वर्ष बघत असताना पहिला सिम्पटम कुठला येतो किंवा पहिलं वळण कुठलं चुकतं, असं जेव्हा आम्ही ऑब्झर्व केलं तेव्हा आमच्या लक्षात आलं की these children are more focused on objects and less focused on humans. आणि उद्या तुम्ही क्लिनिकमध्ये जरी पाहिलंच काही क्लिनिकमध्ये मूल काय करते तर त्याचं लक्ष वस्तूत असतं आणि माणसात नसतं. कुणीतरी ऑटिझमचा चुकीचा हे लावलाय, ट्रान्सलेट केलंय की स्वमग्नता. हे स्वमग्न नसतात, ते काही ऋषी मुनी नाही आहेत की बसून मेडिटेट करतायत, दे आर वस्तुमग्न. आणि आमची जी ट्रीटमेंटची आम्ही एक प्रोसेस बघितलेली आहे की डायरेक्टली वर्दर दॅन वर्किंग ऑन सिम्पटम्स, यू शुड वर्क एट द रूट सिच्युएशन ऑफ द सिम्पटम्स. अँड इफ यू आर एबल टू कट द ऑब्जेक्ट्स, देन द चाइल्ड विल बी मोर फोकस्ड ऑन ह्युमन्स. आणि एक कारण ऑटिझमचं वाढण्याचं हे पण आहे की सध्या ह्युमन एंगेजमेंट मुलांना मिळतच नाही. ही जीन जुनी आहे, पण पूर्वीच्या काळात घरात एवढी माणसं असायची, कोण ना कोणत्या मुलाकडे सारखं इंटरॅक्ट करायचं आणि वस्तू कमी होत्या. पण आता गेले 10, 15, 20 वर्ष वस्तू वाढलेत, एस्पेशली मोबाईल. आणि ती अशी वस्तू आहे की त्याच्यात इतर वस्तू पण लागत नाही. आणि त्याच्यामुळे एपिजेनेटिकली ही मुलं जास्त आणि जास्त वस्तुमग्न होत चाललेत आणि म्हणून ऑटिझमचे सर्व सिम्पटम्स डेव्हलप होत आहेत. अशी एक कल्पना आणि अशी एक थिअरी आम्ही प्रेझेंट केलेली आहे. थँक्यू.
Yes, some questions are there. Dr. Kashmiri, are there fuzzy eater? Why so much of feeling issues in these patients?
Why there are
Feeling issues in these patients, this fuzzy eater.
fuzzy eater, feeding issues?
Yeah,
Okay. Yeah. So basically, feeding issues could be, there are multiple reasons. First is since the childhood, as sir said, ki Indian scenario, they are forcing the child to eat. Just the weight gain is the development for the mother, firstly, and they set the pattern. So that first. Second is these children are having the hypotonia. So these muscles, buccal muscles, they are not achieving, they are not working properly. So that could be the second reason. Third is these children, they have a sensory issues. So all the feel of that food, so the texture of that food, that gets gives the sensation, and that can lead to the fuzzy eating. And one more thing which I read recently, that the dysarthria, mandibular dysarthria, if because the these children have the cortical pathways dysfunction and basal ganglia dysfunction, so this dysarthria could be there. And if it is there, then these children are likely to have a feeding difficulties. I would like to ask Samir sir also if give their inputs.
Absolutely, you're absolutely all right. And that is how we have to, look at that. You're right.
Yeah. Second question is, why multiple therapies theory? What are common therapies required in these autism patients? Common therapies.
So the reason is there is no what I'll say, the one therapy solution we have, or there is no medicine as such. So we have to see the areas where the child has affected. For example, if there is a communication issue, or if there is a sensory issues, the behavior, then the activities of daily living, life skills. So त्याची दैनंदिनी सुरळीत होण्यासाठी ज्या ज्या क्रिया करायला लागतात ते आपल्याला पहिले आयडेंटिफाय करायला पाहिजे. And then we have to use the combination of therapy, as I just said. So therapies which are basically, there are lot list, and everyone is talking about the applied behavioral analysis, then the speech therapy, sensory integration, OTR it requires. And also I use the three different approaches, like the developmental therapy, then the discrete trial therapy, and the pivotal trial therapy. So DDT, PTT, and DT. These therapies I do use in my center, and this is how I deal with the children.
One more question regarding in continuation with this. What is the duration and frequency of therapy, and how long should we continue treatment?
Duration and
frequency of therapy.
Okay. So duration as such, I don't think we can predict the duration of the therapy. It is all based on the improvement and the signs and symptoms of what the child is giving. So it is all depend on the cognitive level of the child, the behavioral stabilization, the development of the skills, which how the child is developing with that. And continuation is like, as I said, child is going to the different phases till the adulthood. So we have to keep a monitor, and as and when required, we have to provide certain therapies to these children. I would like to ask Samir sir about this, because this is a very good question.
So there is a little bit of a difference in what we do. We actually work on a sequence. आणि त्याला आम्ही एक न्यू होरायझन्स सोशल बिहेवियर अँड कम्युनिकेशन सिक्वेन्स म्हणून एक डिस्क्राईब केलेलं आहे. आय विल शेअर द डिटेल ऑर द आर्टिकल इन द chat box. Where the first thing that we have to develop is the human engagement for the child as the first milestone. Then the next milestone is social interaction or social behaviors at the right place, right time. Then there is non-verbal communication. Then there is verbal communication, and then there is reading and writing. So at our center, what we are working with our program is to basically work on these step by step. We don't start directly with speech and reading and writing. So that makes us lose a lot of patience, because that is all that patients want. But the whole problem is, if you want fever to go away, you can keep giving paracetamol. But if it is malaria, the paracetamol will not help. So we try to explain to the parents that there is a pathway, and if you work on the pathway, things get better. So what we first try to achieve is good human engagement, good eye contact, good response to name call. Then the child understanding the correct behavior, what to do where. Then the child picking up non-verbal communication, finally picking up speech, and thereafter reading and writing. So that is a little bit of a different approach that we are taking. But what Dr. Kashmiri said is also absolutely what is followed across the whole world.
Yes, sir. The human engagement in the developmental therapy, the human engagement is the main part of that. I mean, I just gave the name of the developmental therapy. So like there we first the agenda of the child, and we have to bend down, like I bend down at the child level and then work with the child so that he will identify me or he'll notice me, and then the later on the agenda will be mine, and the child will play according to what like we want to achieve from the child. So this is how based on the human engagement only I'm working, sir.
Correct.
Dr. Akhilesh Kalawate want to ask question. He has raised it. Sir, you can unmute yourself and ask the question.
Yeah, I have two questions. First of all, thanks for nice presentation, Kashmiri. The first question is that what is the chances of having ADHD and autism both together? And second thing, if we left the child as it is, means we can see that lots of great persons like Bill Gates and Elon Musk all means below the means have some period of their ages they have diagnosed or they have the spectrum of autism. So if we left child as it is or we have done nothing, what is the chances of child to be developed normal? And what is the medical problems if we have not diagnosed that condition and not told the patient's relatives or parents that there is a problem of autism? Please, Kashmiri.
Yes. First question I can answer, and second I will ask Samir sir to answer. So first, the ADHD and autism, there are 30 to 50% chances the ADHD will be there in the autistic children. So they may have a ADHD with them. And the other one, I'll request Samir sir.
Sometimes I wish that there should be more medical legal awareness, because currently what you see in the field of developmental disorders is Tom, Dick and Harry and their uncle are starting so-called centers and therapy services all across the country in the nook and corner of each and every street. आणि हे डॉक्टरांनी किंवा पूर्वी थेरपिस्ट करायचे, पण चला ठीक आहे, ऍटलीस्ट काहीतरी त्यांचं मेडिकलची घेणं देणं आहे. आता इट हॅज बिकम अ प्रॉपर इन्व्हेस्टर ड्रिव्हन बिझनेस फॉर व्हॅल्युएशन गेम like Byju's. And Tom, Dick and Harry is setting it up, putting in millions of dollars and just having all kinds of malpractice. Only thing is keep doing therapies, keep doing therapies. We are providing OT, we are providing speech therapy, we are providing ABA. पण त्या OT, स्पीच थेरपी आणि ABA काही चुकीचं नाही, पण त्याच्यात त्या सेंटरमध्ये किंवा त्या सर्व्हिसमध्ये काय केलं जात आहे हे बघणं गरजेचं आहे. कारण जर ते सेम पोपट पंचवीस मुलाला शिकवत असेल, से गुड मॉर्निंग, से गुड मॉर्निंग, से गुड मॉर्निंग, आणि मग वर्षभरानंतर मूल गुड मॉर्निंग बोलते, पण रात्री पण बोलते, दुपारी पण बोलते, सकाळी पण बोलते, देवळात गेलं तरी गुड मॉर्निंग बोलते, घरी पण गुड मॉर्निंग बोलते, शाळेत बोलत नाही, त्याला काहीच अर्थ नाही. आणि म्हणून आपल्याला लक्ष दिलं पाहिजे की जे चाललंय हे योग्य आहे की नाही. अजून कोणी त्याच्यावर मेडिकल लिगल ऍक्शन घेत नाहीये, पण पुढे कोण ना कोणतरी नक्की घेणार. आणि म्हणून ऍज अ पीडियाट्रिशियन आपल्याला दोन गोष्टी केल्या पाहिजे. प्रथम, मुलाला जर हे सिम्पटम्स असले तर मी यांना प्रॉब्लेम आहे सांगितलं तर माझ्याकडून पळून जाईल, दुसऱ्या पिडियाट्रिशियनकडे जाईल, असं न घाबरता सांगितलं पाहिजे की प्रॉब्लेम आहे, न्यूरो डेव्हलपमेंटल डिले किंवा डिव्हियन्सी आहे. नेमकी कुठली ती मी सांगू शकत नाही, एवढं मात्र नो प्रॉब्लेम. म्हणून तुम्ही डेव्हलपमेंटल पिडियाट्रिशियनला दाखवा. हे न करताना तुमच्या मुलाला स्पीचचा प्रॉब्लेम आहे का, तुम्ही स्पीच शिकवा किंवा तुम्ही स्पीच थेरपी करा, हे बोलणं कधी कधी अवघड होईल. कारण ते स्पीच थेरपिस्ट चांगले असले तर चांगलं आहे, पण जर ते नसले, त्यांची डिग्री कोणी बघितलेली नाही आणि तेच से गुड मॉर्निंग करत राहिले आणि त्या मुलाचं उद्या नुकसान झालं तर कदाचित तुमच्यावर येऊ शकतं की तुम्ही इथे पाठवली, तुम्हाला माहित होतं का इथे काय होतंय म्हणून, नाही, मग मुलाचं नुकसान झालं. तेव्हा यू हॅव टू पिक अप द सिम्पटम करेक्टली अँड रेफर टू मॉनिटर आफ्टर यू रेफर. जर मुलाचा उपयोग होत असेल, मुलाची आय कॉन्टॅक्ट इम्प्रूव्ह होत असेल, बिहेवियर इम्प्रूव्ह होत असेल, हायपर ऍक्टिव्हिटी कमी होत असेल, स्पीच इम्प्रूव्ह होत असेल, काही हरकत नाही. हे इम्प्रूव्ह होत नसेल, नाही ते चालू ठेवा तुम्ही. मी तेच ऐकलं की हे चालू ठेवायला पाहिजे. तुम्ही इनोसेंटली करतात पण त्याच्यात फसायची शक्यता आहे, तेव्हा असं नका करू. रिफर बट मॉनिटर. थँक्यू.
So as Dr. Akhilesh, you said that the medico-legal. So now this is under the Disability Act. The autism is one of the disability under 21 that disabilities. So could be a medico-legal. We have not seen, as sir said, we have not seen many cases accordingly. And if left untreated, what happens? So it is depending on the level. I feel. So if it is a mild, then level 1, then it is okay. The child may live a normal life. But if it is a moderate to severe level 2, level 3, then it will be difficult for the parents and for the family and the community to deal with the children.
मी बोलू का 1 मिनिट?
हो सर.
डॉक्टर गमतीची
एक क्वेश्चन सर, गमतीचाच क्वेश्चन आहे.
नाही, तुमचं उत्तर मी देतो. तुम्ही जे म्हटलं लेफ्ट अनट्रीटेड काय होतं, मला तुम्हाला असं पण सांगायचं की आफ्टर ट्रीटमेंट काय होतं हे पण बघितलं पाहिजे. चिल्ड्रन गेट वर्स, दे गेट मोर एज पोपटपंची आणि पॅरेट सारखे आणि रोबोट सारखे वागत असतात. कारण बऱ्याच वेळा थेरपीमध्ये त्यांना फक्त पॅटर्न शिकवले जातात. तर ही जी कल्पना आहे की पर्टिक्युलर थेरपी दिल्यानंतर चिल्ड्रन बरे होतील आणि नाही दिलं तर ते वर्स्ट होतील, म्हणून आपण त्यांना ह्या फॅक्टरीजमध्ये जे पळवायचं काम चालू केलेलं आहे ह्याच्यात कुठेतरी आपल्याला एक स्टॉप केला पाहिजे. ट्रीटमेंटने बरं होतं असं नक्की नाहीच काही. किती पॅरासिटामॉल तुम्ही देणार मलेरियासाठी? काही वेळ ताप कमी होतो, पुन्हा ताप येणारच. आणि हे करता करता अल्सर झाला तर तेव्हा बऱ्याच वेळा मुलं जी येतात तुमच्याकडे 3 वर्ष थेरपी केल्या, आईला पण आनंद वाटत असेल की माझं मूल बोलतंय, तुम्ही बोलायचा प्रयत्न करा. आता तुम्ही त्याला विचारलं, आई म्हणते हा नाव सांगतो, तर आई म्हणेल बरं नाव दाखवा तुम्ही डॉक्टर म्हटलं, तर ती म्हणेल व्हॉट इज युअर नेम, तर ते मूल म्हणेल व्हॉट इज युअर नेम समीर. शाबास. मग तुम्हाला चांगलं वाटत, अरे वा वा, अरे नाव सांग रे, काय आन्सर नाही. अरे तुझं नाव काय? नो रिप्लाय. टेल मी युअर नेम, नो रिप्लाय. आई म्हणाल नाही हो डॉक्टर, असं नाही त्याला विचारायचं, मी सांगते कसं विचारायचं. व्हॉट इज युअर नेम, लगेच व्हॉट इज युअर नेम समीर. याला तुम्ही स्पीच म्हणता का? नाही, याला क्लासिकल एकोलेलिया म्हणतात. म्हणजे मिनिंगलेस पर्पजलेस रेपिटिशन ऑफ व्हॉट यू हॅव हर्ड. अशी जर थेरपी दिली असेल तर मूल इम्प्रूव्ह झालेलं आहे असं नाही, बिघडलेलं आहे. पण अमेरिकेत मेजर करत असताना तोंडातून किती शब्द येतात ह्याची मोजणी केली जाते. ते पर्पजफुल आहे, मिनिंगफुल आहे की नाही हे केलं जात नाही. आणि म्हणून एव्हिडन्स आहे की हे केल्यानंतर मुलं बोलतात, पण ती नॉर्मल बोलतात की एक्वलेलिक बोलतात हे तुम्ही आपण पेशंटला फॉलोअप मध्ये चेक केलं पाहिजे. एक्वलेलिक असेल तर त्याचा काही उपयोग नाही. समजून कमी बोलतोय पण समजून बोलतोय असं झालं पाहिजे. हा, आता बोला. सॉरी.
Can I add 1 or 2 line?
मी एक वाक्य बोलतोय.
Wait.
जसं आईन्स्टाईन किंवा इलॉन मस्क, बिल गेट्स सुद्धा काही काळात ऑटिझमच्या स्पेक्ट्रमला अफेक्टेड होतो. मी आता पेरेंट्सला अगर समजवण्यासाठी फक्त एक वाक्य बोलतोय, तो कितपत योग्य आहे तुम्ही मला सांगायचं. तुमचा मुलगा हा एक तर अतिशय मूर्ख असेल किंवा तुमचा मुलगा हा एकदम टॅलेंटेड हुशार असेल, सायंटिस्ट असेल, या एकाच सेंटेन्स मध्ये तुम्हाला कितपत योग्यता वाटते आणि कितपत म्हणजे काय हे वाक्य तुम्ही कसं ग्रहण करता?
समीर सर.
डॉक्टर काश्मीरी, तुम्ही लेडीज फर्स्ट.
They are batchmates, sir. They Akhilesh and Kashmiri are batchmates.
सर तुम्हीच द्या सर.
नाही बॅचमेट ने पहिले,
Batchmate.
म्हातारी नंतर.
सर Sir, since from the PG, he is having some unique and different concepts and different questions altogether. So, Akhilesh, काय होता तुझा क्वेश्चन? परत सांग. सॉरी.
एखादा मी सस्पेक्ट केलं आहे की हा ऑटिझम आहे आणि मी ते पेरेंट्सला एक सांत्वना म्हणून सांगतो की हे इतके सारे महान लोक हे ऑटिझमला आहेत, त्यामुळे तुमचा मुलगा घाबरू नका. तुमचा मुलगा हा एकदम अतिशय मूर्ख असेल किंवा तो अतिशय टॅलेंटेड असेल, सायंटिस्ट असेल, मधात नसेल तो. या वाक्यात तुला कितपत सत्यता वाटते?
थोडस डाऊटफुल वाटतंय वाक्य. कारण पहिलं जेव्हा आपण एखाद्याच्या मुलाला मूर्ख म्हणतो, दॅट शुड नॉट बी देअर. सो जस्ट मॉडिफाय लिटिल बिट की तो मागे राहू शकतो किंवा खूप पुढे पण जाऊ शकतो.
इथं मी वेळ कट करण्यासाठी बोलतोय. ऍक्च्युअली आय नेव्हर यूज सच वर्ड्स.
Okay. So like he may grow, he may do a fantastic things, and he may, if it is a severe level, then he may lag behind.
समीर सर.
जी, इलॉन मस्क किंवा बिल गेट्स किंवा आईन्स्टाईन ची कोणी ऑटिझमची इव्हॅल्युएशन केली नव्हती. हे स्वतःला जरा विशिष्ट दाखवण्यासाठी, वेगळे दाखवण्यासाठी त्या ह्या डिग्र्या लावतात. आणि आजकाल अनफॉर्च्युनेट आहे की ह्या गोष्टींना डिग्री म्हणून मानली जाते आणि स्वतः मी ऑटिस्टिक होतो पण मी असं केलं, म्हणजे मेरे साथ ये हुआ, मेरे साथ वो हुआ, फिर भी मैंने ऐसा किया. त्यातला एक भाग आहे. मैंने बहुत साल फिल्म इंडस्ट्री में स्ट्रगल किया और स्ट्रगल के बाद मैं हीरो बन गया. हे फॅशन आहे. तेव्हा याच्यात काही सत्य नाही की इलॉन मस्क स्वतः म्हणत असेल. आता तो महा करोडपती, त्याच्याशी आपण कुठे भांडणार? बोल बाबा, तुला वाटेल तू खरं आहे, तू हरकत नाही. भारतात 4-5 फॅक्टऱ्या काढ म्हणजे झालं, दॅट इज ओके. पण ह्याच्यात काही सत्य नाही. आणि रियालिटी जर तुम्ही या मुलांची बघितली, नायदर आर दे व्हेरी मूर्ख, नायदर आर दे व्हेरी ब्रिलियंट. पेरेंट्स मूर्खता त्यांची ही अनफॉर्च्युनेटली केली जाते बाय मेकिंग देम स्पेंड ऑल दिस मनी. आणि डेव्हलपमेंट फक्त जे पैसे घेतात त्यांची होते. तर तुमचं वाक्य सत्य आहे, पण त्या मुलासाठी नाही. पालकांसाठी एक एक्स्ट्रीम आहे आणि जे पैसे कमवत आहेत त्यांच्यावर दुसरा एक्स्ट्रीम आहे.
राम सर.
Yeah. I'll just add 1 or 2 lines on the medico-legal aspect. See, in certain diseases, error of judgment is not a medical negligence, but here it doesn't apply because these are altogether different scenario and these are the chronic illnesses. So it's not an acute illness ki fever hai, error of judgment. So wherever possible, you have to refer, as Samir sir said. If you fail to refer and just gives a false assurance, then you are liable and you are held responsible for the medical negligence.
Yes. Yes.
Am I right,
Absolutely
Samir
well
sir?
said. Absolutely well said. Well.
Perfect.
ऋषिकेश
Dr.
सर.
ऋषिकेश सर, kindly unmute.
हो सर. गुड इव्हनिंग टू एव्हरीवन. सर, माझा प्रश्न असा आहे की आता प्रॅक्टिसिंग पिडियाट्रिशियनला याच्यात करायचं डेव्हलपमेंटल पिडियाट्रिक्समध्ये, तर IIP चे काय काय कोर्सेस उपलब्ध आहेत?
आता नुकताच ICP ला एक कोर्स लॉन्च केलाय अमोल, डॉक्टर अमोल पण तुम्हाला सांगतील. आता अनफॉर्च्युनेट असं झालं की त्याच्यात फक्त 40 सीट्स होत्या, कारण त्याचा एक कॉन्टॅक्ट प्रोग्राम पण आहे आणि मग तो फिजिकली 40च्या वर एका वेळी पॉसिबल नाहीये. आता ऑलरेडी त्याच्यात झालेत 50, म्हणजे ते आपण न बोलूया, कारण त्याच्या 500 लोकांना करायचा होता. पण आता ते मुद्दा असाच आहे की आता दिस वॉज अ फर्स्ट एक्सपेरिमेंट की चालू करूया, रिस्पॉन्स कसा आहे. वॅक्सिनच्या कोर्सला प्रचंड रिस्पॉन्स आहे, एलर्जीच्या कोर्सला इंटेन्सिव्ह आहे आणि ऑटिझमला मला वाटतं त्याच्यापेक्षा जास्त आहे. आणि ते आता आपण एकानंतर एक पुन्हा तो कोर्स करत घेऊया. हा IIPच्या दृष्टिकोनाने कोर्स आहे. दुसरा म्हणजे फेलोशिप्स. आता जवळजवळ 20 ठिकाणी, मी जनरली चॅप्टर चेअरपर्सन होतो तेव्हा मी 2017 साली फेलोशिप सुरू केलेले. आणि आता एक 20 ठिकाणी ऑल भारतात म्हटलं तर आपण 20 ठिकाणी फेलोशिप दिले जातात. वर्षाला 22-25 फेलोज पास होतात. माझ्याकडे 2 सीट आहेत, इतर ठिकाणी बरेच सीट्स आहेत. तर ह्या 2 गोष्टी ऑलरेडी IIP करतायत.
थँक्यू सर.
One more question is there. Dr. Kashmiri, what are the challenging behavior in autism?
What are the
Challenging
behavior? Okay. So I have showed in my presentation also. So like there are like 4-5 behaviors usually the child shows. The first is a tangible behavior, that is a हेतू पुरस्कार. तो हेतू पुरस्कार सगळं वागत असतो, त्याला जे पाहिजे ते डिझायर गोष्ट मिळवण्यासाठी तो वागतो. सेकंड इज अ अटेन्शन सिकिंग बिहेवियर. सो तुमचं लक्ष वेधून घेण्यासाठी ही विल थ्रो अ बिहेवियर. Then is the एस्केप बिहेवियर, तो कुठल्या तरी सिच्युएशन पासून तुम्ही त्याला एखादी काम सांगितलंय, टास्क सांगितलंय, त्यातनं पळवाट काढायसाठी तो पळवाट एक काढतो, त्याला एस्केप बिहेवियर म्हणतात. आणि देन द सेन्सरी बिहेवियर. सो आपण जे काही सेन्सरी इनपुट्स मुलांना मिळत असतात, तर ते त्याला वेगवेगळ्या पद्धतीने प्रेझेंट करू शकतात. समटाइम दे आर व्हेरी हायपर ऍक्टिव्ह और समटाइम दे आर व्हेरी हायपो ऍक्टिव्ह. दे विल गो अँड सिट इन द कॉर्नर और दे विल बिहेव एक्स्ट्रीमली screaming and yelling and all that, or they will just roam around here and there and they behave hyperactively. So these are the behavior, and then again the steaming and meltdowns are the behaviors which is I've just said about that.
फक्त मुलांच्या एक आपण बघितलं पाहिजे की त्यांची एन्झायटी किती आहे. आपण मुलांना बघतोय बिहेवियर, हे आपण कुठे बघतोय? आपल्या क्लिनिकमध्ये. आणि आपल्या क्लिनिकमध्ये त्यांना आयदर दे आर नॉट कनेक्टेड, की डॉक्टरांचं क्लिनिक आहे, नाही आहे, त्याला काहीच फरक पडत नाही, किंवा त्यांना प्रचंड भीती वाटलेली असते. कोणीतरी मारलेलं असतं, कोणीतरी बोललेलं असतं, इंजेक्शन लागले असतं. तर मुलाकडे डॉक्टर जे मेडिकली जे करायचं आहे ते डॉक्टर काश्मीरीने प्रत्येक सांगितलं, त्यात काही राहिलेलं नाही. त्याला तुम्ही एमचॅट पण केलं पाहिजे, तुम्ही त्याच्याशी इतर इव्हॅल्युएशन पण डेव्हलपमेंट पिडियाट्रिशियनने केलं पाहिजे. ऍब्सोल्युटली राईट. तुम्ही त्यात थोडक्या वेळात काय करू शकता? शांत राहा. शांत राहा. पालकांना पण सांगा शांत राहा. मुलाकडे शांतपणाने बघा. त्याला कसली एन्झायटी वाटते याचा प्रयत्न करा, विचार करायचा. शांत बसा. हळूहळू त्याच्याकडे जा. त्याला जमलं तर हात आपल्या आधी पुढे करा. खेचायचं नाही, पण हात पुढे करायचा. कारण तो घाबरलेला आहे. समोर काय चाललंय त्याला माहित नाही. ही व्यक्ती कोण? ही माझ्याकडे काय करणार? माझ्याशी कसं वागणार? त्याला माहित नाही. शांतपणे समोर बसा. हात पुढे करा. तो हात देस तर खेचू नका. असं हे वगैरे काही करू नका. शांत बसा. स्माइल करा. जास्त बडबड करू नका. हळूहळू ते मूल तुमच्याकडे बघायला लागेल. आता एकदा बघायला लागल्यावर हसा. वेडेवाकडे चेहरे करा. जोकर सारखे वागा. मस्करी करतो आपण, म्हणजे हाऊ वी मेक फन, असं हे करा. आणि दॅट यू विल सी विल ड्राईव्ह द चाइल्ड्स अटेन्शन मोर टुवर्ड्स यू. तुम्ही एवढं जरी केलं ना, तर दॅट इज अ व्हेरी व्हेरी बिग साइन ऑफ इम्प्रुव्हमेंट दॅट यू हॅव टॉट. आणि पालकांना सांगा, बघा मी काय केलं. मी मुलाशी फक्त एंगेज होतो. मी त्याला एबीसीडी विचारलं का? नाही. त्याला अमेरिकाचं कॅपिटल काय विचारलं का? नाही. ते काय याच्या चुलीत घालायचंय? नाही. नॉर्मल हे जे आहे ते हे इम्पॉर्टंट आहे. आणि लेट देम वॉच हाऊ यू आर एबल टू काम द चाइल्ड डाऊन and how you are going to engage with the child. बोलणं, speech is far, far overrated and unnecessary. Human engagement is primary. First, go for that and let the parents see how you have. आणि बाकी काय झालं नाही तर तुम्हाला डॉक्टर म्हणजे देव म्हणतील, अरे ह्या कोणाकडे जात नाही, ह्यांच्याकडे एकदम एवढा मस्त गेला, एंगेज करतो, हसतोय. फक्त शांत राहा आणि त्याच्याशी हसत, मस्ती करत एंगेज व्हा. एवढं मला सांगायचं. थँक्यू.
Thank you, sir, for practical tips. One thing I want to do from my side, and I am doing office practice module. So we promote Yum Chat. What happens most of the time, general pediatricians are not using the Yum Chat. So my request from my IP is that everybody should use the Yum Chat. Can you say some thing about Yum Chat, Kashmiri ma'am? When to do which question? Most of the time pediatricians are not aware that it is free. You can download it on internet. You can keep it to
It is available easily. You can download on the net, download, and it is available in the Marathi and various languages also. And it is very simple. मी आता मागच्या वर्षी जवळजवळ 400 अंगणवाडी सेविकांना ट्रेन केलेलं, आणि त्यांना आम्ही रिवॉर्ड ठेवलेले की तुम्ही हे परफॉर्म करा. तुम्ही बेबीज तुम्हाला जे डाऊटफुल वाटतात ते घेऊन या, आणि वी यूज टू गिव्ह देम अ रिवॉर्ड. की आम्ही अंगणवाडी सेविकांचा सत्कार करायला लागलो. सो टू फॉर दॅट और देर आर मेनी प्रोग्राम्स वी हॅव कंडक्टेड. आणि त्याच्यामध्ये आम्हाला असं दिसून आलं की आपण व्यवस्थित त्यांना ट्रेनिंग दिलं आणि त्यांचे प्रश्न वेळोवेळी म्हणजे त्यांना समजतपर्यंत एक थोडं आपण त्यांना गाईड केलं, तर एमचॅट आपला स्टाफ सुद्धा करू शकतो. काही प्रॉब्लेम नाही. मला वाटतं
can use train her receptionist, and in we
yeah,
meeting.
yeah.
This is the practical application. So
The
the
only thing
receptionist,
you have to guide her initially. असं नाही की बाबा एकदा शिकवलं आणि संपला विषय, असं नाही. You have to supervise her, and once you are confident that she can do, then only you hand over. Otherwise, no.
patient coming to OPD at 18 months.
If you don't have a psychologist with you, if you have, then okay, she'll be doing that. He or she'll be doing.
I think there are no, and already it is 10:30. Almost 200 pediatricians are still online. So, Dr. Ram Gopal sir, can we conclude the meet?
Kundan,
Sir?
Yes, yes, yes.
Yeah.
Sanjay sir.
Can I just add one more thing quickly,
Yes,
Amol?
sir. Please add. Please
हा
add.
मगाशी त्या थोडं गमतीचा भाग झाला पण बेसिकली व्हॉट इज इट दॅट यू विल टेल द पेरेंट तो मुद्दा राहिलाच सो यू हॅव टू टेल द पेरेंट दॅट युअर चाइल्ड हॅज डेव्हलपमेंटल इश्यूज इज नॉट प्रोग्रेसिंग इन द डेव्हलपमेंट ॲज एक्सपेक्टेड फॉर एक्झाम्पल एका वयात बसणं झालं पाहिजे एका वयात उभं राहिलं पाहिजे एका वयात चाललं पाहिजे तसं एक पर्टिक्युलर वय असतं तसंच डेव्हलपमेंटमध्ये आय कॉन्टॅक्ट ह्युमन एंगेजमेंट बिहेवियर कुठे कसं वागायचं बोललेलं कळणं स्वतः बोलणं हे एका वयाप्रमाणे टप्प्याटप्प्याने झाले पाहिजे हे तुमच्या मुलात थोडंसं कमी आहे किंवा होत नाहीये किंवा उशीर आहे किंवा एका वेगळ्या वळणावर आहे ते नेमकं का आहे आणि त्याचं कारण काय आहे हे तुम्हाला डेव्हलपमेंट पिडियाट्रिशियन सांगू शकतात पण मी मात्र तुम्हाला एवढं सांगू शकतो की हा नॉर्म मध्ये आता नाहीये थोडा पाठी आहे तो पाठीच राहील का पुढे येणार नाही का असं मी काही सांगू शकत नाही तो येऊ पण शकतो पण आता असं दिसतंय की आपल्याला त्याला इव्हॅल्युएट करून घेतला पाहिजे आणि आपण जर व्यवस्थित इव्हॅल्युएट केलं आणि जर काही प्रॉब्लेम निघाला तर त्याच्यात आपल्याला जी इंटरव्हेन्शन करायची असते ती आपण करून घेतली की त्याच्यात तो प्रगती नक्की दाखवेल आणि हे करत असताना मी तुमच्या बरोबर आहे तुम्ही डेव्हलपमेंट पिडियाट्रिशियनना दाखवा त्यांना दाखवत राहा ते सांगतील ते करा पण तुमच्या मुलाचा डॉक्टर मी आहे आणि मी तुमच्या फॅमिलीच्या बरोबर आहे सो यू कीप कमिंग वेन एव्हर यू वॉन्ट आणि म्हणूनच एमचॅट इज व्हेरी व्हेरी इम्पॉर्टंट ईसीडी मध्ये आम्ही 200 वर्कशॉप्स केलेले आणि 10,000 लोकांना एमचॅट सांगितल्यापासून भारतात सर्वात जास्त एमचॅट आता व्हायला लागलाय पण एमचॅट केल्यानंतर डोंट फॉरगेट टू चॅट विथ द पेरेंट्स थँक्यू थँक्यू
Very well said.
कुंदन ये कश्मीरी और समीर सर का जादू है स्टिल 175 people are logged.
Yes, sir. Should we conclude the meet, sir?
Yes, yes.
Any question to audience?
I think most of the questions are covered, sir.
And the chart is disabled for putting the MMC registration number and all this.
Okay.
So you can unmute yourself and ask questions, please.
I put a couple of in the chat box couple of resources. One is an article from Indian Journal of Practical Pediatrics, and one is some of the Instagram videos that we are putting. Feel free to download it from the chat and use it. Thank you.
I think Rushikesh,
Yeah.
Dr. Rushikesh.
Yes.
हा सर काही नाही लास्ट एकच सांगायचं होतं की भरपूर काही आवश्यकता आहे या फील्डमध्ये नंबर ऑफ पेशंट पण वाढत आहेत आणि पिडियाट्रिशियन मध्ये पण अवेअरनेस तेवढा नाही आहे पब्लिक मध्ये पण नाही त्यामुळे फारच गरज आहे मला असं वाटतं
खरंच काम करायची खूप गरज आहे कारण तेव्हा इथे 12 वर्षापूर्वी आलेली त्यावेळी
एवढंच
इथे
बरं आहे.
काहीही सिनॅरिओ नव्हता आणि खूप स्ट्रगल करायला लागलं सुरुवातीच्या काळामध्ये आणि त्याच्यामध्ये एवढं लक्षात आलं की डील विथ द फॅमिलीज बी विथ द पेशंट्स आणि सर जसं म्हणतात की फॅमिलीशी बोला बी क्रिस्टल क्लिअर विथ द फॅमिलीज फॅमिलीला काय करायचं हे सांगितलं तर फॅमिली बरोबर पुढे जातं
Yes.
बरोबर थँक्यू थँक्यू
Dr. Sanjay, sir. Ready, sir.
मला म्हणताय
Yes, sir.
अच्छा
Sir.
wonderfully delivered by Kashmiri ma'am and very well means the comments by the Samit Dalwai sir as an expert and you know everything cannot be learned from the book when the expert says something from his experience it means by attending a 1 hour lecture you get too much even we cannot get after reading 2 4 5 books which is difficult at this time also to read the books so it's very important to attend such particular type of lectures and to get updated and at least to get some pickup points because we get a very small time in the OPD but if you pick up you can do something to the parents to the family and to the society so rather than law means what is there is in medico legally how it will be it's a responsibility to pick up such cases so that those people will get the early interventions and they will be better rehabilitated or will get the better results from which the family will gain something as well as the society and that we should take it as a responsibility of we pediatrician as to give some time or have a stringent third eye as Dr. Ambedkar sir says third eye you had a vision how he walks in your chamber how he's interacting with you in last 5 minutes how he's roaming here and there was he concerned with anybody if you talk with the parents so all these things are very important I think sir has given and madam has given a very good insight so that all the people who have means they are present over today they will definitely get benefited thank you sir and thank you ma'am
Yes.
Very nice.
Ram Gopal sir, should I conclude now? I will do a Thanksgiving. Just I would like to thank our expert, Dr. Kashmiri Badbade ma'am, for giving such in-depth, detailed presentation on autism spectrum disorder. Now all general pediatrician will be able to answer parents' questions to autism. Thanks to Dr. Samir Dalwai sir for chairing the session, and Dr. Ram Gopal sir for attending and giving expert comments. Dr. Sanjay Pakmode sir, President-elect 2025 IIP. Dr. Ramakant Patil sir, MMC Observer for today's event. Then Dr. Amol Pawar, Secretary General. Dr. Bhavesh Mithya sir, Scientific Convener of the MAHA-IP. All office bearers and EBs who have joined this webinar. Today, almost 250 pediatricians have joined the webinar, and out of that, 200 are still present. And also like to thank all of them, and also those who will be watching this YouTube live streaming afterwards, as a we put them on MAHA-IP IIP platforms YouTube channel. And also, I would like to thank Dr. Pallavi Madam and Vishal Raut sir for their technical support. Thank you all, and good night.
Thank you.
Kundan,
Thank
thanks
you.
to you and Mateen also
Thank
for
you,
doing all
Kundan.
this. Thank you so much.
Thank you, Ram
Thank
sir.
you.
Pallavi